Welcome to the Canadian Liver Foundation's 2021 LIVERight Health Forum, Ask the Experts series. Our beloved BC Chapter Board President, Dr. Francis Ho, created the LIVERight Health Forum in 2014, attracting over 1,000 attendees in its first year. Through his leadership, he brought much-needed awareness to liver disease across BC and Canada. Dr. Ho passed away peacefully earlier this year at the age of 89. He will be sorely missed, but his legacy and teachings will continue on. Like last year, this week-long virtual health forum will present valuable information on important topics relating to liver disease and liver health. To kick off this week's sessions, we have the pleasure of introducing our first speaker, Dr. Eric Yoshida, a highly respected liver specialist who has many accomplishments over his 30 years of practice. He is a full professor at UBC and is well known nationally and internationally in the area of liver disease and liver transplantation. He is the chair of the Canadian Liver Foundation's National and BC's Medical Advisory Committee and the chair of our LIVERight Health Forum. Today, Dr. Yoshida will be talking about knowing your hepatitis ABCs. Please join me in welcoming Dr. Eric Yoshida and our host, Valeria Zaborska.
Well, thank you for joining us, Dr. Yoshida. It's an absolute pleasure to interview you again.
Well, thank you. Thanks for that kind of introduction, and thanks for inviting me to participate. I would just like to say that having known Dr. Ho was professional assistant for many years, his passing was what was a tremendous loss to those of us in the liver community. Dr. Ho was extremely dedicated. He had passion that was second to none, and I am quite happy that this forum will be his legacy. Thank you.
Absolutely. Okay, so to kick off the presentation, Dr. Yoshida, can you tell us what is hepatitis? What are the general signs and symptoms, and how is it typically diagnosed?
Well, hepatitis simply means that your liver is inflamed and there's damage going on. It can be viral, it can be immunologic, it can be, I suppose, it can be metabolic. It's all to some extent just rhetorical and semantics. But the key thing is that it implies that there's damage to the liver and there's inflammation going on. A lot of times there's no symptoms. The liver has a tremendous reserve. By the time you really have symptoms of liver failure, you're functioning on probably 10% or less of your liver reserve. Some infections like viral hepatitis acutely can have a significant amount of symptoms, just like any flu-like illness, just like COVID-19, fever, chills, feeling terrible, that kind of thing. But a lot of times they have very few, and chronic hepatitis often does not have many symptoms. Hepatitis C can sometimes have a lot of non-specific but well-recognized symptoms.
Okay, so maybe we can start with hepatitis A. Can you tell us what exactly is hepatitis A and how is it spread?
Well, thank you. Hepatitis A is a viral hepatitis. It's a picornavirus that is transmitted via the fecal-oral route, and it typically does not occur sporadically during outbreaks, point source outbreaks like a restaurant or a food manufacturer has contaminated food from an employee who had hepatitis A and contaminated it, perhaps didn't wash their hands after going to the washroom, and then people get infected, they get acutely ill, they feel terrible, they feel like they've had the worst flu of their life, they can have diarrhea, and then they turn yellow, and their liver biochemistry is like really deranged. And most of those people will actually recover, and once you recover, you have lifelong immunity. But the key is that a certain small percentage overall will have liver failure and need a liver transplant or will die. And the likelihood of that depends on how old you are. So overall, it's probably about 1 to 2 per 10,000 if you look at all people with hepatitis A. But if you are middle-aged, if you have chronic diseases, could be diabetes, could be chronic liver disease like cirrhosis or alcoholic liver disease or any kind of liver disease, or you just simply have a lot of other comorbid conditions, heart problems, lung problems that are serious, the mortality is higher. It can actually even be as high as 1%. So hepatitis A is something that is potentially serious. And I should add that hepatitis A is preventable. A vaccine can give you lifelong immunity, and you don't have to worry about hepatitis A. Hepatitis A is also found in some communities more often than others. Typically, the developing nations tend to have more hepatitis A. Southern nations tend to have more hepatitis A, that kind of thing. Whereas in Canada, where it's cold and the hygiene is pretty good and the level of health tends to be pretty good, it usually only happens in point source outbreaks.
And so you're mentioning that vaccines are the best way to prevent hepatitis A. But what about if you already get it? Is there a treatment available, or do you just wait for it to run its course?
If you already have acute hepatitis A, you simply have to let it run its course. Mm-hmm. And if you are middle-aged and with a chronic disease and your hepatitis A is causing liver failure, then the course of action would be supportive care in a hospital setting where they can provide you with the medicines you need to bridge you until you recover. And if your liver is really going into failure and it looks like there's a chance you may not survive, then an urgent liver transplant assessment would be necessary.
Thank you. So moving on to hepatitis B, can you tell us what hepatitis B is, what causes it, and what does it mean to be a carrier?
Well, hepatitis B is very common throughout the world. Hepatitis B is a DNA virus, and there's two modalities. There's acute hepatitis B, and then there's chronic hepatitis B. So acute hepatitis B, depending on how old you are when you get it, you get acutely ill, or you may not even realize you're ill, and you can clear it. But chronic hepatitis B means that you have it lifelong. Now, it all depends on how old you are when you get acute hepatitis A. Acute hepatitis B. Now, if you are a baby and your mother has hepatitis B and you got it at birth, what we call vertical transmission, you won't have any symptoms because you're a baby, and you certainly won't remember it, but you will probably have hepatitis B for the rest of your life. If you are an adult when you get it and you got it through transmission, horizontal transmission, and usually that's sexual transmission, but it can be the other kinds of transmission, injection of drugs that for which there have been shared needles, contaminated medical equipment, contaminated body piercing or tattoo equipment, then there's about a 90% certainty that you will get very ill, but you will clear the virus and you are less likely to have chronic hepatitis B. Now, a carrier simply means that you have hepatitis B all the time, you're chronically infected, and you're called a carrier. It's the same as saying chronically infected.
So when you say that someone can naturally clear the infection, meaning that you've had it implanted in your DNA and then you have the antibodies from it, does this have any repercussions for the future? So for example, if you have to have chemotherapy or you become immunocompromised, if you have cleared it, can it ever come back, or does it mean that you're cured?
If you have hepatitis B and your immune system clears it, which means that this marker called the hepatitis B surface antigen is no longer present, you still may have minute dormant quantities of hepatitis B living in your liver sequestered. Under normal circumstances, it doesn't mean anything. It won't bother you. For all intents and purposes, you're a normal person from a hepatitis B perspective. But you get an unusual circumstance where you have cancer. They have to give you very potent chemotherapy that knocks out your immune system. Or you have some kind of autoimmune disease, whether it's inflammatory bowel disease or whether it's a rheumatologic disease, and they give you a very potent immunosuppressive medication like there's lots of them, infliximab, high-dose steroids, cyclophosphamide, any of those things. There is a small chance, less than 5%, but certainly not zero, that hepatitis B can suddenly reactivate. And sometimes that can actually knock your liver out.
So now going back to the previous question about how hepatitis B is spread, if someone in your family has it in the household, is there something you can do to prevent yourself from getting it?
Just like hepatitis A, there's a very effective vaccine against hepatitis B. And in BC, everybody is vaccinated at birth. In other provinces, they only vaccinate the kids when they're like older, like maybe grade 6 or something, which does not make any sense to me because all the kids are going to get vaccinated eventually. So why not just vaccinate everybody at birth? But there's a very effective vaccine. But don't worry, you can't get hepatitis B just by casual contact. For instance, if you're at a dinner party and the person sitting at your table has hepatitis B and you don't know about it, well, don't worry, you're not going to get hepatitis B from that. You shake somebody's hand and they have hepatitis B, you're not going to get hepatitis B from that at all. So unless there's actual body fluid contamination or sharing, you are not going to get hepatitis B. It's like you can't get hepatitis B just by using the same hairbrush. Using the same toothbrush is a different matter, though, because there's minute particles of blood. So don't share toothbrushes. But otherwise, I wouldn't be that fussy. You can eat at the dinner table with somebody with hepatitis B. You can watch television with them. It's not like coronavirus. You won't get hepatitis B.
Great, thank you. Since there are no early signs or symptoms, if left untreated, how severe can hepatitis B get, and what is its long-term effects on the body?
Well, classically, 30% of people with hepatitis B over their lifespan, if something isn't done about it, they may be at risk for cirrhosis, and they certainly are at risk for liver cancer. With liver cancer and with cirrhosis, when it's in its early stage, people don't even know they have it. It's only when it's too late to perhaps do something without transplantation or other things, then people have symptoms. So with cirrhosis, again, the liver has tremendous reserve. It's only when your reserve dips to less than 10% that you actually start having symptoms, like you turn yellow, you start getting fluid in your belly, you might develop varicose veins in the esophagus, which if they get too big and pop, you're going to have massive bleeding, or all these toxins that your liver clears are going right into from the circulation into your brain, and you get confused. Those kind of symptoms only happen when you have much less than 10% reserve, and when that happens, you need a liver transplant. Just like liver cancer, when it's small, you won't even know you have it. But the thing is, you want to catch them when they're small so somebody can cure you of it.
What is the mainstay treatment for hepatitis B at the moment?
The mainstay treatment right now is antiviral medications, which are available. They're oral pills. They're covered by BC Pharmacare for the most part, depending on certain criteria. They don't have many side effects. And just like HIV, antivirals, once you start, you really probably should not stop. Those are the mainstay treatments. But not everybody who has hepatitis B will need treatment. Otherwise, in British Columbia, the pharmacare budget for antivirals would basically be like hundreds of millions to billions of dollars. It would perhaps bankrupt them. So you have to be selective about when you're going to start taking the antivirals, knowing that once you start, you are probably going to be on this for a long time, if not indefinitely.
And so you mentioned earlier that you shouldn't stop taking the meds. So if someone is on medication and they feel better, what can happen if they stop taking them?
Well, that's a classic mistake. And let me tell you, in the liver transplant program, once every 1 or 2 years, we have to urgently transplant somebody who was perfectly well, but they stopped their hepatitis B antiviral drugs, and then their liver went into total failure, and restarting could not save the situation. In almost the majority of patients, once you stop the antiviral, at some point the virus will come back, and sometimes it comes back with a vengeance. Just like HIV, if you stop your HIV antiretroviral drugs, well, your HIV viral load will go up, and then your white cell count, your CD4 count will come down, and then you get into trouble. It's the same kind of situation.
So now moving on to hepatitis C, can you please tell us what the difference is between hepatitis C and B, and which one is more common?
Well, they're basically both bad viruses. They're basically both bad viruses that you really ideally don't want to get. Hepatitis B is a DNA virus. Hepatitis C is a RNA virus. The main difference with hepatitis C, okay, they can both cause cirrhosis, they can both cause liver failure, needing a liver transplant, and they can both cause hepatocellular carcinoma. And the bottom line is they're both very dangerous viruses. But the main difference with hepatitis C is that there is effective treatment that you can take for 8 to 12 weeks with almost no side effects. Actually, I would say very few side effects. And you can be cured in about 95 to 99% of the situation. That is the main difference.
Okay. And how is hepatitis C spread?
Hepatitis C is spread multiple ways. Most common is via body fluids. It used to be that back in the 80s, when the blood supply wasn't screened because they didn't have a screening test, that people got hepatitis C via a blood transfusion. That was a tragic thing. There were a lot of people who got into trouble that way. The other is through the use of injection street drugs, or even snorting cocaine can sometimes transmit it. It's also important to appreciate that sometimes it can be transmitted from mother to child, depends on how high the viral load is in the mother. But again, that is on the order of perhaps 5 to 15%, depending on what studies you read. It can be transmitted sexually, but I'll be honest, it's kind of difficult to transmit sexually. The risk of sexual transmission is thought to be not non-existent, but still very low.
Okay. So in terms of, this is a question from the audience, does family history play a role in either hepatitis B or C, in terms of, can you be genetically predisposed to be more likely to get it, or are they completely unrelated?
Oh, they're completely unrelated.
Okay, great. And how do you treat hepatitis C,
Well,
and how do you
going back to
pay
your
for
question,
it?
Val,
Yeah.
okay, if your mother has hepatitis B and your mother has hepatitis C, yes, they could give it to you. So let me qualify that. But general, if it's like your brother or your aunt or your uncle or your grandparent, no, it doesn't. That won't make any difference.
Thank you. Sorry, I jumped ahead a little bit. Can you tell us a little bit about how you can treat hepatitis C and whether that's covered by pharmacare the same way the hepatitis B treatment is?
Oh, there are excellent drugs. There's 3 combinations on the market. I'll use the trade names. They're both combination pills with 2 drugs. Well, one of them, called Vilsebi, has 3 drugs. But there's Vilsebi, there's Epclusa, and there's Harvoni. They are marketed by Gilead Incorporated, and then there's LIVERight, which is marketed by AbbVie Incorporated, and then there's Zepatier, which is marketed by Merck Incorporated. They are all excellent medications, and they are all covered by BC Pharmacare under certain conditions. But basically, Pharmacare has lifted the restrictions that they used to have, so the limitations are generally administrative, like you have to have a viral load and a genotype within a certain time of application, otherwise the patient has to get the blood test again, that kind of thing. So they're not really real barriers.
And once you're cured from hepatitis C, can you get it again?
Generally, if after 6 months after treatment, your hepatitis C is undetectable in your blood, you are basically cured. The only way of getting it again is if you engage in some risky activity in which you got a new infection. There are some rare cases where somebody was hepatitis C viral load undetectable at 6 months, but then 1 or 2 or 3 years later, the virus appeared and they did genetic sequencing. They found it's the same virus, the original virus, but those are kind of rare. It raises eyebrows, but it's extremely rare. I would say it's like much less than 1%. I have only seen it happen once or twice, and I've seen thousands of patients, so it's extremely rare.
And then last question about hepatitis C. Do vaccines exist for it?
Unfortunately, no. The virus is too smart for a vaccine to be developed. The virus changes, like a leopard that changes its spots, the virus changes its proteins all the time. It generates these mutations spontaneously that help the virus evade the immune system. And when you have a circumstance like that, it's kind of like Star Trek and the Borg, where the Borg changes its shielding so that phasers are ineffective. Exactly that. So the virus changes itself so that the immune system is less effective or not effective against it. And when you have a situation like that, it's hard to develop a vaccine because the vaccine is there to prime your immune system.
Well, thank you so much for all those details about hepatitis A, B, and C. So people often get those three mixed up, so thank you for clarifying them. Some confusion also happens with two other conditions, which is primary biliary cholangitis and primary sclerosing cholangitis. So there are a couple of questions from the audience about those two conditions as well. So this is a question from an audience member. I've had PBC for 2 years. As it progresses, what should I expect and watch for? Are there any new treatments or clinical trials for it? And how can one participate if such trials exist?
Well, with primary biliary cholangitis, or PBC, it is an indolent disease that a natural history is literally decades. And not everybody who has PBC is going to need a liver transplant. Only a small minority is going to. And most patients actually don't have many symptoms at all. Some patients get itching, and of course, patients who develop cirrhosis and the liver is failing will develop all the things I talked about with hepatitis B and C. But by and large, a lot of patients don't have many symptoms. PBC is an autoimmune condition, and it has a host of autoimmune manifestations. One of them is what's called SICA syndrome, SICCA, if somebody wants to look it up on the internet. That's where the immune system kind of compromises the salivary and tear glands, so that it's common for patients who have dry eyes and dry mouth. That's not directly related. It just means that PBC happens in a milieu in a dysregulated immune system. There's a lot of other immunologic manifestations that are associated with PBC, not related to the liver, but just to a dysregulated immune system. A lot of rheumatologic conditions affecting the joints and musculoskeletal system have reported to be associated, that kind of thing. There is effective treatment. The standard treatment is ursodiol, or ursodeoxycholic acid. This is a bile salt. Your liver produces a small amount of urso, but it's been found to be beneficial. The actual mechanism is not quite known yet, but we're just giving you more of the good stuff. And because your liver produces a small amount of urso, it's unlikely that you're going to be allergic to something that your own liver produces. Urso is a major constituent of bear bile, so that's why you would sometimes see in alternative health shops that they were selling bear bile and bear gallstones, the contents of bear gallbladders. Well, you have to kill bears to get that, but with urso deoxycholic acid, they know how to synthesize the actual molecule, so no bears were hurt in the process. There's another medication that's been on the block for about maybe a couple of years, been in clinical trials for a lot longer, called obeticholic acid. The trade name is Ocaliva. That is for patients who are on urso but are getting a suboptimal response and their liver biochemistry is still bad, and that is a second-line add-on agent. And that works in a proportion of cases as well.
Great. Okay. And the next question is, how frequently is inflammatory bowel disease associated with primary sclerosing cholangitis?
Now, that's a good question. Primary sclerosing cholangitis has an association with inflammatory bowel disease. People who have primary sclerosing cholangitis, let me call it PSC for short, depending on what studies you read, it's anywhere from 50 to 80% of people with PSC will have inflammatory bowel disease, either Crohn's disease or ulcerative colitis. Looking at it the other way around, though, it's only a small minority of patients with inflammatory bowel disease who have PSC, like on the order of 5 to 10%. So it all depends on which way you look at it. But if you have PSC, inflammatory bowel disease can be quite common.
And is there currently treatments for PSC, or is there research being done for future treatments?
Well, currently there really is no effective therapy like PBC or viral hepatitis. They're short of a liver transplant, and PSC can recur after a liver transplant. There really is not currently on the market an effective treatment that if you don't get it, you can get angry with your doctor about. You can't do that. But there is the pharmaceutical industry has put a lot of effort into looking for a medication, and there are clinical trials ongoing. And if you want to get into a clinical trial, you simply just have to ask your doctor, and they can tell you whether your local university teaching hospital or community hospital is a site for that clinical trial. That's the way clinical trials work. Not every hospital or doctor's office is involved.
Great. Well, thank you so much. That's the end of our questions. It's been a pleasure having you here.
Oh, thank you.